Hello, everybody. Today we are here to talk about a very interesting subject. I have many people who ask me about this problem, and it's a very common problem from people in young age till older people, mostly in older people, older meaning like 35 to 45. This issue arises. It could be many reasons. It could be the cause of this. We're talking about low libido, Libido, or low sex drive. It has a big variety as far as just not being interested or not being able to have any satisfaction from this activity. We have today Dr. Foojan Zeine to help on this matter. She's a trained psychotherapist. Dr. Foojan Zeine, it's good to see you again.
Good to see you, Dr. Naim.
Yeah, so we're going to talk about low libido. As I said, I see patients on this regularly. It could be many reasons that causes this. As you know, it could be just relationship problems, could be hormonal problems, it could be medical problems that causes this in women. So one of the treatments that we have, usually I try to counsel them. I might refer them to a specialist such as you. We're going to sometimes give them medications. I'm going to talk about the medications that are available for these problems. But before I go on, maybe you can give us some idea as from your point of view that what kind of patients you see, what problems you see, and what kind of treatment you might offer them.
Sure. If I see someone who is young and they are in their prime time of sexual activity, or their body needs to be that or shows up as that, and they have a low libido, I'll start assessing whether it is a hormonal or a chemical issue, and then obviously I send them back to you for you to assess for their hormonal rates. However, if that's not the case, we got to look at a couple of matters. They might have depression, and that depression definitely lowers the libido. They might have been taking some other medication, and this is part of the cause. Like, for example, if they are taking antidepressant, most antidepressant kind of lowers the libido. These people might have been abused as a child, sexual abuse as a child, and they might have that kind of a depression plus the trauma that does not allow them. They won't allow themselves to actually open their body or even feel pleasure, or fear might show up if they actually allow themselves to fear pleasure. Or that they are in a particular relationship and the relationship is no longer working, and their inability to work through the relationship, or somehow they've resigned in the fact that the relationship isn't working. So it becomes colder and colder. And one way that they shut down their body and emotion is shutting down their libido first. And many times it's just a matter of the working through the relationship and bringing them back into that space. Some people are not even connected to their body. Like, even if they go and do a massage, they won't really feel it. And that's why even if they are part of a system of a sexual experience, the intensity of felt experiences are not there. So it's more of treating them in how to get to their body and feel the sensation. So as the sexuality shows up, that they're really wanting it. Because many times I've heard when people have bad experiences with sexuality, they automatically kill off their own libido because they don't want to have that desire, because the minute they have the desire is as if now they have to face a low point. So even when I've worked with people who are in marriages or with relationships that their husbands or their mates, the male partner does not have, they have maybe erectile dysfunction, or they don't have a libido because of a low testosterone, I've watched the women also kill off their libido because they don't want to have an affair, they don't want to go off, so they have to kill off their desire.
So subconsciously they might be doing it, or you're saying, can only like one bad experience cause this, or one bad situation causes like it come like a post-traumatic stress disorder or something like that? Would that be a reason sometimes?
Definitely in abuse, in rape, in anything that has violence would do that. Or if they are with a partner that they create like sexual performance anxiety with each other, then you can see that immediately the other person shuts off also. And then you see this next in when women are going through menopause.
True, menopause. So a lot of patients, could be just dryness, could be an issue, could be sometimes just hot flashes and not feeling comfortable with their body. A lot of times these patients, we treat them with estrogen and they respond good. But a lot of them also they need further help in this matter.
Absolutely. Menopause is very much a hormonal and a psychological prospect because it's a different phase. That means you no longer are going to have a child, and childbearing years of a woman is complete at this time. That becomes a grief of a phase of life that you have to say goodbye to. And then you also, with this phase of life, you go through a lot of grief. It's as if the grief of, your youth, your ability as a female to procreate, you're not having the libido. If your hormones are not that great, it's almost like it's fast forward to aging. It's usually the time that the women also, their children are out of the nest or flying out of the nest. So trying to figure out, who am I? What is my identity if it's no longer being a mother?
Some women might actually feel that it might be better for them. The fact that they don't have to worry about getting pregnant makes them easier for some. I would say probably a lower percent of people, but most of them do have issues when they have menopause. I'm going to talk quickly about the treatment that I give the patients. Medical treatment, of course, when they come, they do evaluation, physical exam and maybe an ultrasound and things like that. We do hormonal tests. I check the testosterone, the estrogen, the progesterone. But as far as the treatment, what is on the market and what I might offer to patients, something called the passion cream, which is a mix of the cream that they use, aminophyllin and arginine. It's supposed to increase the blood flow to the vaginal area and makes it more sensitive. That's one treatment. A lot of time we give patients testosterone. This is a low dose testosterone, usually in 2 milligram per cc in female. It's also being used for men, but that's like about 50 milligrams. So that's almost like 10, 20 times higher. You can have either the cream of them, or you can have something that you dissolve under the tongue. That's the way you can give to the patients. There is no pill for that because it doesn't go through the liver. There is 2 other medicines on market. I'm going to talk quickly about them. One is called Addy, ADDYI, which is a pill that you take every day. It's not like Viagra for men. It has to be taken every day. It kind of balances the neurotransmitters in the brain, like dopamine and serotonin, has been shown to increase sex drive or increase libido in women. The main problem with this medicine causes dizziness, sometimes fainting, especially with drinking alcohol. So that's the only thing with it. The last medicine that is recently came on market called Vyleesi, that's Vylesi, which is the subcutaneous injection. So you inject it under your arm. This one is as needed, PRN as we say. That means that it's kind of like Viagra or Cialis, that before you want to have a relationship, you inject it and it affects the melanocortin in the brain. This is the receptor that affects the sex drives and also other things like hunger, and has been shown that to make a difference. So these are the medications that we try on the patients. But a lot of patients don't want to go that far. They usually want something else.
We don't have to go to emergency room after 4 hours?
Hopefully not because of medicine. Maybe because of other reasons, maybe, but not this one. They do have, all of them have side effects. Again, they're not very comfortable to be using. I don't have that many patients that use them. Most of them try testosterone or something on the arm that might help them. They go with that. But I've seen a lot of them to see therapists, and they do see a difference. I have a question for you. Do you think if a person has an issue, do they have to come with a partner, or just a female patient can come and see you without going or telling the partners what problem they have?
I would suggest for the female to come in first, because we want to do an assessment about all the different areas. And if it's part of their grief or they're coming to terms with their new body and who they are and their new identity, they don't necessarily need their partner to be there. However, if we assess that part of this has to do with the combination of the relationship and what's going on in the relationship, then we will invite the partner in.
I see. The one other question that also is a concern: if somebody's in a relationship and doesn't have a libido, if the medicine doesn't work, therapy doesn't work, what are the options? I mean, usually these patients don't want to have an extramarital situation or find different partner. If they be thinking about such an option, what would you tell them in that regard? Would you counsel against it? Would you try other things? I know there are people who do things called surrogate. There are people that might be helping a couple in the bed or things like that. Do you have any information about that situation?
I think that the question is there an issue within the sexuality performance, or there's a libido? Because the libido is the original desire.
True.
So then it's a matter of, okay, some people might not have the original desire, but if they allow themselves to say yes, then with different types of, let's say, with foreplays, the desires can come up. So it's more of the allowance to put themselves into that situation. And then the communication, there are exercises that can be done that creates communication between the couples that shows different types of erogenous zones or different pleasure by touch, different spots that they can find, and make it into a play. Like, enjoy sexuality as two people coming to play, and it's no longer about just the performance of insertion anymore. And I think when we take that away and we make these times as a playful concept of emotional intimacy and fun, you see that people start coming together, because they don't think that the minute I start and say hello, then it also has to go to a complete, insertion. So at that point, you'll see this just lightens up. So the ability to give yourself the allowance to say no or yes, or let me begin and play. And I don't have to, I don't have to be committed to any type of an ending. And when the two couples do this together, they have fun together, pretty much.
True.
True.
That makes sense. The one last thing I want to talk about is also cultural. A lot of it is cultural. When the kids, when the kids and they're grown up, what they tell them, what's not to do, and when they grow up, some female have more restriction on that. And also, even when they're older, I have patients who, at even like 73, 74, 75 years old, they're active, but some of the patients that's around the menopause, they say, I'm too old for this, I cannot do it anymore. It's kind of, is a taboo for them to do it. So that's also could be relevant, and a lot of them, just get information to them makes a difference for them. Dr. Zeine, thank you very much. It was very informative. I appreciate your help. Hopefully we can work together, and I appreciate the time you gave us. Thank you very much.